Today I will share 5 important things we must know about chest tubes and pigtail catheters before ICU rotations. This is the first of a series of videos discussing frequently encountered tools in the ICU. Let's get started. A chest tube is that hollow, flexible tube we place into the pleural space to drain air, blood, or fluid so the lung can re-expand. A pigtail catheter is simply a smaller, softer version of a chest tube with a curled pigtail tip. Both do the same job, removing air or fluids from around the lung. But the big difference is in size and invasiveness. Chest tubes are larger and preferred in emergencies, while pigtails are thinner and often chosen for more stable situations like draining fluids or small pneumothorax, and more conveniently, patients can be discharged home with if needed. Let's first discuss the indications to place a chest tube. Traditional large bore or traditional chest tubes in general are indicated in emergency situations or if the clinical scenario is requiring rapid high volume drainage, or when the fluid is viscous or contains debris such as traumatic hemothorax, large or viscous pleural effusions like empyema, chylothorax or malignant effusions, post-operative thoracic surgeries, persistent air leak, particularly in mechanically ventilated patients, while pigtail catheters preferred in stable patients with simple effusions, small, spontaneous, and iatrogenic pneumothoraces, or they need to go home with it like in chronic recurrent effusions. Let's move and talk about the chest tube unit. But before that, if you'd like to receive a summary of this video delivered to your email, kindly subscribe to my Substack page and newsletter. The subscription link is provided in the description field. So let's talk about the chest tube unit. An adequate chest drainage system aims to remove pleural fluid and or air, prevent their reflux back into the pleural space, and restore negative intrapleural pressure, which is less than atmospheric pressure, to allow lung re-expansion. So to understand how chest tube achieves that, we must understand the component of the chest tube drainage unit or system. Back in the days, the chest tube unit was simply a tube connected to a bottle filled with some saline and a one-way valve. While this works well for draining air like pneumothorax, it does not work well for fluids. If a pleural effusion is drained, the fluid level in the bottle will quickly increase, reducing the efficiency of removing additional fluid from the patient. So to solve this problem, a second water seal bottle was introduced. This leaves the first bottle for collection only. And by the way, to understand the water seal, try to blow some air in a cup of water. You will see all these bubbles, correct? Can you suck that air back now? Of course you can't. The air gets sealed in the water. So this is the two bottle system, one for collection and one for water seals. To make drainage more efficient, a third bottle connected to external suction was added or can be added. This makes the 3-bottle drainage system: a collection bottle, a water seal bottle, and a suction bottle. Nowadays, all these chambers or bottles are integrated in a single, modern, functional, easy to manage system. In this picture, you can see the collection chamber, the water seal chamber, and the suction chamber. Notice the air leak monitor in the picture. Remember, this will come back to it. Now, the tube itself comes in different sizes and shapes. They can be straight, angled, spiral, or coiled at the end like in pigtail catheter. Once a chest tube is placed, we must confirm proper positioning with a chest x-ray. Ideally, the tip of the chest tube should be positioned at the apex if inserted for pneumothorax, and at the base if inserted for fluid removal. Ensure the tip or the fenestrations are not outside the pleural space or abutting the mediastinum. Take a look at this chest x-ray. You see the chest tubes is toward the apex, likely was placed for pneumothorax, and it's in good position. And in this chest x-ray, we can see a pigtail catheter at the lung base draining fluids. And in this chest x-ray, you can see a pigtail catheter that's abutting against the mediastinum. It should be pulled back. Take a look at this chest x-ray. You can see that one of the chest tube fenestrations is outside the pleural space. The fenestrations are these evenly spaced gaps, interruption marks along the radio-opaque stripe of the tube. The fenestration should be inside the pleural space to allow effective drainage of air or fluid while reducing the risk of clogging or blockage. Multiple holes also distribute suction evenly, preventing tissue traumas and ensuring continuous continuous tube function. So please ensure to review the chest x-ray before you round on your patients. Now, what are the daily bedside checks when rounding on a patient with chest tube? Again, although a daily chest x-ray is not necessary in patients with chest tube who are stable, it must be obtained if there was a change in the patient's clinical status after major adjustments, repositioning, or removal of the chest tubes, or if there is a persistent air leak or a persistent fluid drainage or large fluid drainage. Now, in the patient's room, check the following. By the way, it's highly recommended to have the patient nurse at bedside with you. First, assess the output in the collection compartment. What kind? Is it bloody or not? Is it increasing or decreasing? You can ask your nurse about it. Next, check for something called tidaling. Tidaling is the rise and fall, as you see in this video, of fluids in the water-sealed chambers with breathing. It tells you the chest tube is working and still in contact with the pleural space. If tidaling disappears, it means one of two things. Either the lung has fully expanded, which is good, or the tube is blocked, which is bad. If the patient's breathing comfortably, chest x-ray shows full lung expansion, and there are no signs of distress, that's good. But if the patient is short of breath, there is new subcutaneous emphysema, or the tube looks kinked or clogged, this is bad. It means there is obstruction and should be fixed immediately. Next, check for bubbling. Do you see any air bubbles in the air leak monitor we mentioned earlier? Bubbling means air is still escaping. It could be from an ongoing air leak in the pleural space or a disconnection in the tubing outside the chest. Please listen to this. Never clamp a chest tube if bubbling is present. If you do, tension pneumothorax can develop quickly. Next, check the dressing and assess the tube integrity from the dressing to the tube unit. Particularly if you see continuous bubbling in the air leak monitor, that may mean disconnection in the tube set. And don't forget to assess the pain level. Chest tubes, especially large bore ones, are painful, so ensure adequate pain control, please. And don't forget to ask them to ambulate. Chest tube does not mean they cannot be ambulated. And lastly, ask your question, do they still need the chest tube? This brings me to chest tube removal. Chest tube should be removed only by the team who placed and actively managing it. Typically, the ICU team, thoracic or cardiovascular surgery team, or trauma surgery team. Removal is considered when the active issue has resolved, whether fluid or air, the lung has fully expanded, and the patient is clinically stable. For example, in cases of draining fluid, the amount of fluids in the collection compartment is consistently low. For example, you see for the last 2 days, it's 20 cc or less. And for pneumothorax, you don't see any air bubbles in the air leak monitor and for 1 to 2 days, and the lung has fully expanded. Typically, chest tubes is clamped for a period of time, typically 12 to 24 hours. Clamping deems the tube not functioning, as if it's not there. So if the patient's conditions remain clinically stable with a stable chest x-ray, even with clamping, that means it's time to remove the tube. And please do not clamp the tube on your own unless you are part of the team who's actively managing the chest tube. Again, don't ever clamp a tube if you see bubble in the air leak monitor. Now, some patients, you cannot remove the tube. They may need the tube for weeks and months, like in malignant effusion or recurrent pleural effusion. In such a case, a traditional chest tube can be replaced with a pigtail catheter to go home with. Let's discuss some pitfalls and warnings here. Do not connect chest tube to suction immediately after insertions to reduce the risk of re-expansion pulmonary edema. Re-expansion pulmonary edema is a non-cardiogenic edema happens when a lung that's been collapsed for days is rapidly reinflated. The fragile capillaries leak, flooding the alveoli. Management is supported with oxygen, non-invasive ventilation, and cautious fluid. Diuretics may worsen hypovolemia and are not recommended here. But the real key is prevention. Never drain too much too fast. Watch for blocked or clogged tubes. No drainage, but the effusion is enlarging. Sometimes some use thrombolytics to inject directly into the tube to declog them. And again, please correct any tube kinking or dislodgement immediately. In the end, if you like this video, I'm pretty sure you will like my next video on NG tube and PIG tube. So make sure to subscribe and enable notification to watch it as soon as it's released next Thursday. And if you'd like to receive again a summary of this video delivered to your email, subscribe to my Substack. The link is provided below. Thanks for watching, and I'll see you soon.